There it is. Okay. What's the Z line? Okay. Remember, this is the transitory line between the cell types, between the GI lining cells and the esophageal lining cells. They're separate. That line is that Z line. People who have suffered a stroke are at risk of what due to problems with their oral pharyngeal motility? Okay, aspiration pneumonia. Where would you get esophageal strictures? That has to be damage to the lining of the esophagus, either through like acid burns and through the thickening of the remodeling, the stricture happens. But strokes, remember, there's like 5 cranial nerves that are involved with swallowing. You can't have them eat or drink because of aspiration pneumonia. They're going to swallow the contents into the lungs, and they have problems. What is the main histological finding in Barrett's esophagus? Okay, do they have a Z line? No, it's been obliterated, essentially. Do they have esophageal tissue with Barrett's esophagus? No, it's been replaced. Goblet cells. Goblet cells should not be in the esophagus. And remember, this is the link that starts between Barrett's esophagus causing cancers, all these different cell type changes. A portion of the stomach protrudes through the diaphragm, causing upward displacement of the lower esophageal sphincter. What is this called? Everyone's favorite PD exam, diaphragmatic excursion. That's not the answer, guys. Hiatal hernia, that's all it is. Remember, there are different types of hiatal hernias. One where it just comes up and slides back and forth, but then you have the one where it constricts and that stomach tissue gets stuck up there, but they're both hiatal hernias. What is the neurological cause of dumping syndrome? Which one of these will cause dumping syndrome? Okay. Autonomic dysfunction. That causes the opposite of dumping syndrome, which is what? No. Dumping syndrome, guys, remember, dumping syndrome is not what you think. It's coming from the stomach, not the other way. Dumping is from the stomach, motility is too fast. You dump it all out into the small intestine. Okay? Autonomic dysfunction causes gastroparesis from diabetics. They get autonomic dysfunction, gastroparesis, hypotension, stuff like that. Peripheral neuropathy, that's just due to diabetes. Demyelination disease, that's your MS and GBS. Non-selective vagotomy, you cut the vagus nerve. Any type of GI surgery is going to potentially cause dumping syndrome afterwards. What is the major enzyme that is deficient in congenital adrenal hyperplasia? Okay. This is your 21 alpha hydroxylase. It provides the door to get to cortisol and aldosterone. When you don't have it, you don't make cortisol and aldosterone. In a patient with CAH, what would you expect of cortisol, aldosterone, and their androgens? Which answer best aligns with that? So we know they have CAH. So what two are they not making, we know? They're not making aldosterone, they're not making cortisol, so those both have to be low. Now we're left with the androgens. What happens to all the byproducts if we can't make cortisol, we can't make aldosterone? All of those byproducts, all those ingredients, all get made into androgens. So you have high amounts of androgens. That's why you get male secondary sex characteristics in females, because of the extra androgens that are being developed from this issue. Hirsutism, deepening of the voice, so forth. Which of the following is a lab finding seen with Addison's disease? First of all, what is Addison's disease? Low cortisol, low aldosterone as well. Mainly low cortisol. So we know we don't have cortisol. Which one of those answers matches up with a lack of cortisol? Okay. Why hyponatremia? What two enzymes or hormones are you losing? Cortisol and aldosterone, right? Lack of aldosterone, hyponatremia, hyperkalemia. Okay, it's the aldosterone effect. Remember what aldosterone does? If you don't have it, what happens? Okay, a patient has a TSH secreting pituitary adenoma. What kind of hyperthyroidism is this? Please read these answers. Two of them should not even be there because I already told you it's hyper. The question? Please read. Okay. Secondary hyperthyroidism, because the problem is with the pituitary gland, not the thyroid. Okay, bright red blood per rectum is also known as what? Okay, this is hematochezia. What is melena? What's the difference between melena and hematochezia? Upper versus lower. Very good. How is chronic gastritis associated with pernicious anemia? What's the link? Think about gastritis. What are we not producing when you have gastritis? What are you not producing or deficient in production of? Intrinsic factor. Intrinsic factor is the problem. Okay? So remember, it's made in the stomach, but where is it reabsorbed? Terminal ileum. But it starts in the stomach. So gastritis can cause pernicious anemia due to decreased intrinsic factor. Patient complains of abdominal pain a few hours after eating with a 5-pound weight gain recently. What is your likely diagnosis? So they have painful abdominal pain a few hours after eating, and they've gained weight. So make sure when you're studying, you really look at the differences between these two types of ulcers. They're very specific. Okay. Duodenal versus a gastric ulcer. Which one causes the pain immediately? Gastrics. And because of that, what don't they want to do? Eat. So they lose weight with a gastric ulcer. With a duodenal ulcer, pain happens a few hours later. Why? It takes time for the stomach to take all the food and then eventually dump it into the duodenum, and that's when you feel the pain. And then when you eat again, the stomach stops dumping out the food and hold on to it again, and you feel better. So they gain weight because when they eat, they feel better. With regards to the cholelithiasis, that's just gallstones. If I said cholecystitis, that might be an answer. What would I have to put in the question if it was cholecystitis? What type of meal? Fatty meal. Because remember, why fatty meal is important for gallbladder? Because the gallbladder has to squeeze to get the bile out, and it causes a lot of pain when that happens. So that's what cholecystitis. Cholelithiasis has nothing to do with the meal, whatever. And then gastritis, nothing to do with those things either. Okay, what type of large intestine disease affects only the colonic mucosa? Just the mucosal layer. Which one is just the mucosal? Okay. Ulcerative colitis, very good. Remember, Crohn's is transmural. It goes across the whole thickness of the small intestine. What are some other signs, differences between Crohn's and ulcerative colitis? How does it look? What does Crohn's look like? Cobblestoning from all the tortuous edema going on in the area. Ulcerative colitis, flattened, atrophic, ugly, sure. Small intestine. Eventually, the muscle layer gets paralyzed and that's when you get the toxic megacolon, but it's not a complication, it's not a disease. And osmotic diarrhea, nothing to do with it. What is a key diagnostic indicator in a patient who has secretory diarrhea? So you have 4 types of diarrhea. Make sure you understand each of the types, and have an example of what causes each one. But there's 2 answers here. Obviously, there's opposing answers. One of them has to be the answer. And make sure you know which one it is, and there you go. So, secretory diarrhea, because something is causing this to happen, and a bug, microorganism, something is causing your intestines to secrete a lot of fluids. Whether you eat or not doesn't matter. With osmotic diarrhea, because what you're eating doesn't get absorbed by our body, so it just stays in the small intestine, causing an osmotic gradient, pulling water in. If you stop eating, you won't have that stuff in your intestine anymore, and the diarrhea goes away. So if you're lactose intolerant, that's an osmotic diarrhea. Some of the laxatives that people take causes an osmotic diarrhea. Again, you're eating something that your body can't absorb, so you set up a shift, and that causes fluid to rush into the intestine, giving you diarrhea. What is the name of the autoantibody in Graves' disease? Don't confuse the red and the blue. They are two separate things. Make sure you pick the right one. They look similar. I know we just learned it 20 minutes ago, but. First of all, Graves, hyper or hypo? Hyper. So we have to turn on things. Okay, anti-TSH, it's blocking the TSH from doing anything. Are you going to get any thyroid hormone from that? No, hypothyroid. Anti-TPO, where do you see that? And anti-TG, where do you see that? High in concentrations in Hashimoto's thyroiditis, which is a hypothyroidism. TSH receptor autoantibody sits in the receptor, turns on that thyroid gland, and you get hyperthyroidism. What physical exam finding would you expect in a patient with Graves' disease? What are some physical exam findings? When you're studying, don't study the signs and symptoms for both hypo and hyper. They're the opposite. Study one. You know, if it's tachycardia, it's got to be hyper. If it's Brady, it's got to be hypo. Why study both? Just study one. The opposite's going to be true. Hyperreflexia, brittle hair, puffy eyelids, bradycardia are all signs of hypothyroidism. What is the underlying pathophys for the weight loss seen with hyperthyroidism? These are all things that will cause weight loss. Okay, so you will get questions throughout your time in PA school. All four answers are correct. All four will cause weight loss. But the question is talking about hyperthyroidism, and only one of them works with hyperthyroidism. Okay, very good. High metabolism. You suspect your patient has mixed edema. What would you expect her thyroid panel to show? Actually, this is a bad question. I want to skip this one because I didn't go over it very well. I'll review that. I'll make an announcement for that one. Mixed edema. I confused you guys. Okay, mom brings her 2-month-old baby in due to hoarse cry and constipation. Puffed up, dull-looking face. What's your diagnosis? Again, infant with this. Gigantism. Can you have gigantism in a baby? What is gigantism? Gigantism is excess growth hormone before the epiphyseal plates close. Okay, Addison's disease, you won't see that in a 2-month-old. PCOS won't be in a 2-month-old baby. Cretinism is what happens with the babies. Which of the following is a cause of secretory diarrhea? So I talked before about osmotic diarrheas, and I gave some examples. I already gave you 3 of them. Which one of them is secretory? Okay, laxatives. Some laxatives can cause secretory diarrhea as well. Sorbitol, lactose, those cause osmotic diarrheas. What hormone is secreted from the D cells in the pancreas? What is glucagon? What cells? Alpha. What is pancreatic polypeptide? F. Insulin. Somatostatin. D. Okay. Which of the following is the way issues with insulin can lead to diabetes? Okay, all starts with resistance, insulin resistance. Okay, last two. What is the mechanism for ketone body formation with type 1 diabetes? In order for ketones to form, what must not be present? Insulin. You can't have any insulin. So lack of insulin causes breakdown. Well, yes, carbs cause the insulin to rise, but yes. Okay, last question. You diagnose a 48-year-old female with type 2 diabetes, BMI is normal. What question in the HPI can shed light onto why she's got type 2 diabetes? Goes to your history taking. So no family history of diabetes. Which one, type 1 or type 2, is more genetic component? Type 2. So there's no family history. That won't give you any answers. Family history of type 1 doesn't matter. She's taking exogenous insulin. That won't cause her to get diabetic. History of gestational. Remember, 50% of gestational diabetics during pregnancy will get type 2 later in life. Ask that. Did you have gestational diabetes when you were pregnant? That's why you got diabetes now. Okay, I'll post these lectures over the weekend.